Shondell, and I want to make sure that you have taken off mute.
Yes, thank you. Good afternoon, everyone. My name is Shondell Dawson. I'm the Senior Program Specialist with the Family Violence Prevention and Services Program. We're located in the Family Youth Services Bureau that's a part of the Administration for Children and Families. I want to thank you all so much for joining us today and welcome you to this webinar entitled The Intersection of Intimate Partner Violence and Economic Factors. The FIPSA program is co-hosting this webinar with our colleagues in the Office of Planning and Research and Evaluation, and I will be introducing Seth Chamberlain, our Senior Social Science Research Analyst from OPRE, in just a few minutes. We're very pleased for you all to be joining us for this Domestic Violence Awareness Month webinar. It will focus on the intersections of intimate partner violence, economic abuse, and poverty. Speakers will provide an overview of the National Intimate Partner and Sexual Violence Survey and explore the intersection between economic factors for victims of domestic violence and sexual violence, as well as discuss the policy implications for service providers. Domestic violence is the third leading cause of homelessness among families in the United States. It's also very devastating and costly for the families that we serve, as well as for the local communities that are striving to help everyone who's in crisis. In the United States, intimate partner violence, rape, physical assault, and stalking total cost around $8.3 billion each year for direct medical, health care services, and loss of productivity from paid work and household chores. So efforts to eliminate poverty and increase self-sufficiency of individuals and families are directly related to the prevention and reduction of domestic violence. And research suggests that domestic violence victimization is associated not only with recent food, but housing insecurity, unemployment, and disadvantaged neighborhoods. Approximately 6 out of 10 Americans strongly agree that the lack of money and steady income is often a challenge faced by survivors of domestic violence when leaving his or her abusive partner. We also know that those experiencing intimate partner violence also face challenges in maintaining steady employment. In 2003, CDC study found that violence against women, violence against spouses, and dating and intimate partners cost nearly 8 million days of paid work lost for victims of domestic violence. Today you will be hearing from not only my colleagues at OPRE, but our colleagues from the CDC as well. And we're very pleased to be talking to you about the impact of domestic violence and looking at this intersection more closely. For those of you that don't know, the FIPSA program funds and serves 1.3 million domestic violence survivors a year across the 1,600 shelters and 1,100 non-residential programs that are funded through the Family Violence Prevention and Services Act. We're pleased to be celebrating our 30th anniversary this year. I will share some resources about that a little later in this presentation. But I wanted to give you just a bit more of an overview of the FIPSA program. Not only do we support domestic violence shelters, we also support tribal domestic violence programs, a national domestic violence hotline, and a network of national resource centers. The slide here shows the overview of the FIPSA network of domestic violence services. It gives you a clear understanding of how we are supporting local communities and partnering with local communities to address domestic violence across the country. These are just service statistics that I've mentioned earlier about the FIPSA program. You can see a breakdown of the number of women, men, and children that are served each year in FIPSA programs. Work very collaboratively across the federal government. This webinar is a testament to the work that we've been doing with OPRE, our colleagues at CDC. We've been working with both federal agencies within HHS and beyond to try and help agencies have the ability to not only recognize domestic violence, be able to respond appropriately with trauma-informed strategies, and refer survivors to the network of domestic violence services that we support across the country. And over this last month, we've been working with OPRE as well as our colleagues in ACF to highlight national domestic violence awareness, articulating ways that social service providers, healthcare providers, child welfare workers, Head Start workers, child care workers, and those working within the Office of Community Services as well as within the Office of Refugee Resettlement and TANF agencies can all work together to think about not only the impact of domestic violence, to be more knowledgeable about the resources that exist within local communities, build stronger partnerships, and share that information across the state agencies and with their grantees. And that has led to the dissemination of information memos that are featured on our website, which I will share the link to you at the end of this presentation. I just wanted to share a few examples of OCSC, of different commitments around addressing domestic violence through our partnerships. We've worked with the Office of Child Support Enforcement. We've also worked with the Office of Head Start. And Seth, when I introduce him, will talk briefly about the collaborations that we have with OPRE today. We know that focusing on the issue of domestic violence can be very challenging for others, as it is for ourselves and the families that we serve. And we always want to make sure that you're connected to resources and know what those resources are. So we wanted to share links and information to the National Domestic Violence Hotline, talk to you all about an e-learning module that we have around Domestic Violence 101. There's a link there for you all to access that, as well as remind you all about the network of domestic violence state and coalition, territorial coalitions that exist across the U.S., as well as the FIPSA state administrators. There are links there. These are important partners for you all to have as you're moving forward with your workday today. I want to conclude with just a plug for how our website can be a resource to you all, staying updated on the work that our grantees are doing, as well as best practices and looking at research, and we can be reached at www.hhs.gov/FIPSA. And lastly, we'd like to invite you to help continue to tell the FIPSA story and learning about the 30-year commitment that we have to creating opportunities for safety within local communities. Please visit learnaboutfipsa.com to learn more. It is now my pleasure to introduce my colleague, Seth Chamberlain. As I mentioned before, Seth is a senior social science analyst with the Office of Planning, Research, and Evaluation. And we have been working together for a couple years now. OPRE has been significantly supportive of not only talking about domestic violence, but thinking about ways that we can evaluate and document the great work that's happening within programs. Seth has focused on a range of issues from youth, family formation, family functioning issues, such as adolescent pregnancy prevention, strengthening families, responsible fatherhood, and domestic violence. He also works on issues related to low income, as well as at-risk LGBT and transgender populations. I am pleased to pass the floor now to my colleague, Seth Chamberlain. Seth?
Thank you so much, Shondell. It is a pleasure to be on this call on this very important topic. Intimate partner violence is a widespread problem in the United States. In response, my office, which sits within the Department of Health and Human Services Administration for Children and Families alongside FIPSA, our office has recently initiated a project in collaboration with FIPSA and ACF's Office of Family Assistance to strengthen appropriate approaches to addressing intimate partner violence in the context of healthy relationship programs. And we have also initiated another project in collaboration with FIPSA to document how intimate partner violence hotlines funded by the Administration for Children and Families are linking the public with needed resources. 1 in 4 women and 1 in 7 men have been the victim of severe physical violence at the hands of an intimate partner in his or her lifetime. These men and women are more likely to report a variety of poor physical and mental health problems, including chronic pain, difficulty sleeping, and activity limitations. The risk of intimate partner violence is significantly higher among individuals with lower incomes. Almost 10% of women with incomes less than $25,000 a year reported rape, physical violence, or stalking within 12 months prior to a survey that we'll be talking about later in this webinar. That's 10% compared with 6% for women with incomes between $25,000 and $50,000. and 3% with those with incomes at $50,000 or higher. So we can see why there is a definite intersection between intimate partner violence and economic factors. I look forward to the 3 presentations, and at the end of this call, I'm going to tell you a little bit more about the new research that my office has initiated in collaboration with TIPSA. At this point, I'd like to turn it over to Ann Menard with the National Resource Center on Domestic Violence, who will introduce our presenters.
Thank you, Seth, and thank you, Shondell, for that welcoming the partnerships that you've built between the Family Violence Prevention and Services Office and the Office on Policy Research and Evaluation is very valuable to us and makes lots of things more possible at the community level. So we appreciate your leadership. This webinar will focus on the intersection of intimate partner violence and a range of economic factors, including poverty. We have 3 excellent presenters today. The first is Dr. Matt Breidling from the Centers for Disease Control and Prevention, who will provide an overview of the National Intimate Partner and Sexual Violence Survey. Next, Dr. Jennifer Majasko, also from CDC, will explore key economic factors as they affect domestic violence and sexual violence. And finally, I will close with a discussion of some of the policy and practice implications of this intersection of intimate partner violence and economic factors. After each presenter, we'll take a few minutes of questions, and we'll also have time at the end of the webinar for additional questions. So please use the chat feature to pose questions as they occur to you, or comments for our presenters, and we'll try to capture as many of those as possible. Let's get started. It's my pleasure to introduce our first speaker, Dr. Matt Breidling. Matt is a behavioral scientist in the Division of Violence Prevention at the Centers for Disease Control and Prevention. His primary area of study has been the public health surveillance of intimate partner and sexual violence. He was involved in the development of the National Intimate Partner and Sexual Violence Survey, which he'll be talking about. He has also served as the principal co-investigator of a national study of childhood sexual violence in Swaziland. Dr. Breidling holds a PhD in counseling psychology from the University of Notre Dame. Matt?
Hi, good afternoon. Today I'm going to provide a brief description of the National Intimate Partner and Sexual Violence Survey, and I'm going to be presenting results using data from the first 2 years of data collection that we've analyzed so far, 2010 and 2011. Where I can, I'll discuss the most recent estimates from 2011. However, some of the more detailed analyses that we've done has only been done using the 2010 data, and so I'll report on those. But we'll try to be clear about when I'm using which particular data set. And then finally, I'll discuss the implications of the results that we found. So the National Intimate Partner and Sexual Violence Survey was funded and launched by CDC's National Center for Injury Prevention and Control in 2010, and we received support from the National Institute of Justice and the Department of Defense. It's an ongoing nationally representative telephone survey that assesses experiences of sexual violence, stalking, and intimate partner violence among adult U.S. women and men. And it has the potential to provide both national and state-level data. So the primary objectives are really to describe the prevalence and characteristics of sexual violence, stalking, and intimate partner violence, who is most likely to experience these forms of violence, and then the consequences and impacts of these forms of violence. It's really in this area that the report expands upon the information in the previous reports. So to give you a sense about what we're talking about, at CDC we love to show the public health model that's the basis of much of what we do. The NISVS work fits squarely in the first block or step of the public health model. Specifically, it attempts to quantify the problem of intimate partner violence, sexual violence, and stalking. But you'll also notice that once prevention programs have been developed and widely adopted, the model loops back to surveillance with the idea that surveillance really should be able to identify changes in the public health burden that are brought about by prevention efforts. So it's our hope that over time NISVS can serve this function as well. A couple of things about what makes NISVS unique. Previous surveys have primarily been conducted within the context of crime or public safety, but not everyone really considers these types of violence victimization to be a crime. And so NISVS is the first national study using a health context, and part of that was to improve the disclosure. We believe that that would enhance disclosure amongst victims, make them more comfortable. NISVS is focused exclusively on violence, and the number and range of experiences included is much broader than other surveys, national surveys anyway. In fact, NISVS assesses 60 different violent behaviors, including some forms of violence that really haven't been measured before in a national survey, such as 4 types of sexual violence other than rape, what we would label being made to penetrate someone else, sexual coercion, unwanted sexual contact, and non-contact unwanted sexual experiences. It also describes technology-assisted forms of stalking, which haven't been assessed before in a national survey. NISVS asks a large number of behaviorally specific questions, and that we think allows respondents a little bit more comfort in disclosing information. And through discussions between researchers and practitioners, it really became apparent that the data needed to be collected in a way that's consistent with how victims recall experiences. For example, although researchers may think of rape and physical violence as 2 distinct outcomes, survivors who experience these multiple forms of violence by a single perpetrator tend to think of the experience, or may tend to think of the experience as a whole. So asking questions that focus on individual forms of violence and the consequences of that specific form of violence are likely to affect reporting. And so we really group a lot of the follow-up questions by perpetrator, and so we're able to assess what exactly happened in particular relationships. The NISVS has been designed to be consistent with the way victims recall experiences of violence. So all behaviors, as I said, are linked to a specific perpetrator. NISVS captures patterns of violence, for example, by collecting information on all forms of violence experienced by a particular perpetrator, the victim's relationship to that perpetrator, the frequency of the violence experienced in that relationship, and then also the impact of that violence by individual perpetrators, whether they were injured, whether they were fearful, whether they needed various services, whether they missed days of work or school. That tells us a lot about the overall burden of the intimate partner violence experienced. So in terms of data collection, NISVS uses a dual frame sampling strategy. So that means we include both landline and cell phones. In 2010, about 45% of the interviews were conducted by landline and about 55% by a respondent's cell phone. The survey was conducted with respondents from all 50 states and the District of Columbia. Completed interviews were obtained from about 16,500 adults in 2010 and about 12,700 adults in 2011. In both years, females made up a somewhat higher percentage of the sample compared to males, and the interview typically takes about 25 minutes. So looking at the most recent data, and again, I've talked about NISVS generally, but this particular presentation is focused on intimate partner violence. So I'll be excluding any results related to sexual violence experienced by non-intimates, as well as stalking experienced by non-intimates. So everything will be related to intimate partners in the remainder of the presentation. So for stalking, in 2011, we found about 9.2% of women and 2.5% of men had experienced stalking by an intimate partner in their lifetime, about 2.4% of women and 0.8% of men in the preceding 12 months. We did not do statistical testing in 2011 yet, but in 2010 we did and found that women were significantly more likely than men to experience stalking in their lifetime and in the preceding 12 months. Physical violent acts in NISVS included being slapped, pushed, or shoved. In addition, NISVS asked about forms of severe physical violence, including being hurt by having your hair pulled, hit with a fist or something hard, being kicked, slammed against something, choked or suffocated, being beaten, being burned, and having a knife or gun used on the victim. And you can see the estimate for 2011 on the slide. In 2010, we found similar numbers, and women were more likely than men statistically to experience physical violence overall, as well as both of the larger categories. We broke it down into severe physical violence and being slapped, pushed, or shoved. Looking at 12-month prevalence of physical violence by an intimate partner, in 2011 we found 4% of women and 4.8% had experienced physical violence by an intimate partner. And then you can see the breakdown by severe and whether they experienced being slapped, pushed, or shoved. In 2010, when we did statistical testing, there were no significant differences between women and men related to physical violence in the preceding 12 months. And then looking at sexual violence, we see that about 8.8% of women and 0.5% of men had experienced rape by an intimate partner in their lifetime. In terms of other forms of sexual violence, about 15.8% of women and 9.5% of men. Those were statistically significant in 2010. If you look at 12-month sexual violence by an intimate partner in 2011, about 0.8% of women reported rape by an intimate partner. Too few men reported rape by an intimate partner in the preceding 12 months for us to produce an estimate for men. And for other forms of sexual violence, about 2.1% of women and 2.1% of men reported that. So from this point forward, I'll only be discussing 2010 data, where we did some statistical comparisons by demographic groups, which is the primary focus of the presentation, particularly economic indicators and how they relate to the prevalence of intimate partner violence. Much of the results I'll be showing will be a combined estimate that we only reported in 2010, which is the overall prevalence of having experienced rape, physical violence, or stalking by an intimate partner. So in 2010, we produced that combined estimate, and the differences in lifetime prevalence between men and women were statistically significant. And that translates to about 42 million women and 32 million men in their lifetime, or in the past 12 months, about 7 million women and 5.7 million men. So looking at the lifetime prevalence by racial and ethnic group among women, approximately 54% of multiracial women, 46% of American Indian, Alaska Native women, and almost 44% of black women experience one or more of these three forms of IPV in their lifetime. The red circles indicate significant differences. In this case, differences between each of these three groups and white non-Hispanic women. So multiracial and black women had a significantly higher prevalence of these forms of IPV than white women, and Asian or Pacific Islander women had a significantly lower prevalence compared to white non-Hispanic women. Men show a similar pattern. Approximately 45% of AIAN men, 39% of multiracial men, and almost 39% of black men experience one or more of these forms of violence of IPV in their lifetime. And AIAN, multiracial, and black non-Hispanic men had a significantly higher prevalence of these forms of violence than white men. The prevalence for Asian or Pacific Islander men could not be calculated because too few men in the sample reported these forms of intimate partner violence. So looking at 12-month prevalence by income level, Seth talked about this a little bit earlier, about 9.7% of women with incomes under $25,000 and almost 6% of women with incomes between $25,000 and $50,000 reported these forms of IPV in the last 12 months. And this is significantly higher than the prevalence among the comparison group, which are women with incomes higher than 75%. So a similar pattern for men, about 7% of men with incomes under $25,000, and almost 7% of men with incomes between $25,000 and $50,000 reported these forms of IPV in the past 12 months. And that's significantly higher than the prevalence amongst the comparison group, men with incomes of $75,000 or higher. And then in the NISVS survey, we collected data on what we call food insecurity and housing insecurity, and they were measured by these questions. Basically, in the past 12 months, how often would you say you were worried or stressed about having enough money to buy nutritious meals, or having enough money to pay your rent or mortgage. And we found that almost 12% of women who experienced food insecurity in the last 12 months also experienced rape, physical violence, and or stalking by an intimate partner. And that's compared to about 3.2% of women who did not report food insecurity. Similarly for men, 8.2% of men who experienced food insecurity also reported these forms of IPV, compared to about 4% who did not report food insecurity. And these were all statistically significant differences. Very similar findings for housing insecurity. About 10% of women who experienced housing insecurity in the last 12 months also reported IPV in the same time period, compared to about 2.3% of women who had not experienced housing insecurity, and almost 8% of men who experienced housing insecurity in the past 12 months reported IPV during the same time period, compared to 3.1% of men who did not experience housing insecurity. So for both women and men, this was a significant difference. So I'll note that while we didn't control for demographic variables such as income, education, race, ethnicity, and age in this particular analysis, I have run subsequent analysis that controlled for these demographic variables, and food and housing insecurity both remain very strong predictors of victimization. And that suggests that independent of income and other variables, when the economy is poor and stress is high about meeting financial obligations, IPV is likely to increase. At CDC, we often get questions when there's an economic downturn about, do we have any data suggesting that people are experiencing more IPV? There's a pretty strong hypothesis about that. And up to this point, we really haven't had the data to look at that, and we still don't. But NISVS has the potential for that as we accumulate more data every year that can be mapped upon economic indicators to directly look at that. But these food and housing insecurity analyses are kind of an indirect way to look at that in the meantime. So just to summarize, we found that a number of groups are disproportionately affected in terms of intimate partner violence victimization: Black and multiracial women and men, American Indian and Alaska Native men, those who have lower incomes, those who are younger. We didn't report on that in this presentation, but that's another thing we found. Those experiencing recent food and housing insecurity. And then, again, I did not present the results today, but in another report we also identified that women who self-reported as being bisexual were more likely to experience rape, physical violence, or stalking by an intimate partner. So just a couple of mentions of the limitations. We believe the estimates are likely an underestimate. One potential reason for that is respondents that may be currently involved in violent relationships may not participate in the survey or fully disclose the violence they've experienced because of concern for their safety. And we potentially mitigated some of this by the use of a cell phone survey, a cell phone sample, but random digit dial surveys may not capture some populations that are living in institutions such as prisons, military bases, college dormitories, or those living in shelters or who are homeless. And those folks may be more likely to experience intimate partner violence. And because they weren't sampled, they were unable to contribute to the findings. There are always issues with respect to recall and self-report, such as telescoping or the tendency to perceive events in the past occurring sooner than they actually did in reality. And while NISVS went to greater lengths than many previous surveys in terms of trying to measure the context of the violence, we were not able to assess the motives for violence, which is an important aspect of context. And for example, some of those identified as victims within the study may primarily be perpetrators, and the violence they report may have simply been self-defense on the part of the victim. So there's still work to be done in terms of trying to disentangle some of those issues. And then just ignore that last bullet. I'm not sure how that got in there. We did report on services and other reports, and found issues with utilization and availability, but it was from another report. So In terms of implications of the results, there's a need for ongoing data collection. By combining estimates, we hope to be able to present more fine-grained 12-month state-level estimates, as well as to examine trends over time. The results of the study suggest who we might target for limited prevention and intervention resources by identifying those who are most at risk. We identified a number of groups. While this report describes the variation in severity using a number of different indices, the ultimate goal is to identify subtypes of intimate partner violence or particular risk factors for IPV that lend themselves to specific prevention and intervention programs, and those really require studies of perpetration, whereas this examined victimization. And so finally, the NISVS really speaks to the need to look beyond to the context of the violence experienced, because some of these overall prevalence estimates really gloss over a lot of the differences there are, particularly between men and women, between various racial ethnic groups. And so it's really important to look at the patterns of violence, whether multiple behaviors were experienced, the severity, duration, frequency, the impact, the overlap of different forms of violence, to really get at a true picture. And NISVS makes efforts in that regard, but like I said, there's still more to be done in terms of really painting a picture of what's really going on. So, finally, if you want to look at the 4 reports that we've put out so far, you can go to that web address and pull those up. And then if you have any questions after the briefing, please email the email address on the slide. So thank you, and that concludes my talk for today. Happy to take some questions.
Sure. Thanks, Matt. This is Ann Menard again. It looks like there were no questions posed in the chat, which means that you were crystal clear, I think, in your presentation, which is great. But I do have something I'd like you to just extend a little bit. I think one of the important contributions of NISVS are the findings related to impact and the care you took to gather information on the different ways that victims are impacted by intimate partner violence, including the disproportionate impact of intimate partner violence on women. So I wonder if you could extend that a little bit, including what you found about injury, fear, concern for safety, and other types of impacts.
Sure. So we, as I had mentioned, we measured a number of different impacts, whether those who experienced violence were fearful, concerned for their safety, whether they'd experienced any PTSD symptoms, physical injury, a need for a variety of services, including medical care, housing services, victim advocate services, legal services, whether they contacted a crisis hotline, whether they missed at least one day of work or school, contracted a sexually transmitted infection, or became pregnant. So a long list, and we found that women were significantly more likely to experience any of these impacts. But then when we looked at them individually, women were also significantly more likely to experience every single one of these impacts. So, when you look at the overall lifetime estimates, there's not, a great deal of differentiation, although, they were statistically significant in terms of differences. But when you look at, how they were impacted, there are some very stark differences, particularly as it relates to the more severe impacts. And so that, really speaks to the need to drill down. And what that I think recognizes is that, as we found in some of our other analyses, women are more likely to experience multiple forms of intimate partner violence. They're more likely to experience the more severe forms. They're more likely to experience a greater frequency. So it's, there's a lot missing in these overall prevalence estimates that, we do have to report, but sometimes people want to take those and run with them and not really look at what's going on. It's just a very complex situation. There are many different motives. There are many different types of situations. So NISVS at least tries to disentangle some of that.
Thank you so much. I think we'll leave it at that, but encourage presenters. Matt's going to be on the webinar until the end, so if there are questions that occur to you, use the chat to post. We will make sure to address them. It's now my pleasure to introduce our next speaker, Dr. Jennifer Majasko. Jen is also a behavioral scientist at the Centers for Disease Control and Prevention. Her areas of expertise include the use of behavioral, ecological, and life course approaches in understanding individual, family, school, and community influences on adolescent and adult functioning in order to inform prevention, intervention, and policy targeted at at-risk populations. Since coming to the CDC, Jen has been engaged in the development, implementation, and evaluation of programs and policies around youth violence, sexual violence, and intimate partner violence prevention. She earned her PhD and a master's in public policy from the University of Chicago. Jen, the floor is yours.
Thanks so much, Anne, and hello, everyone. As Anne mentioned, I'll be talking about the role of economic factors and economic support in preventing and escaping from intimate partner violence. I want to call your attention, of course, to the acronym that I'll be using. Since I'm a federal employee, I have to throw out an acronym. So I will refer to intimate partner violence as IPV throughout the presentation. And before I dive in, I just have to give the standard disclaimers and disclosures, but most importantly, I want to acknowledge my CDC colleagues at the Division of Violence Prevention, in particular Phyllis Holditch-Nyolan and Linda Ann Valley, who contributed significantly to the content that I'll be presenting today. And a lot of this can be found in an article that was published last year in the Journal of Policy Analysis and Management, and the references provided at the bottom of this slide if you're interested in learning more about what I will talk about. So in terms of precisely what I will cover today, I will cover 6 things. The first thing I'm going to tell you about are IPV typologies and what the literature says about whether they exist and what those are. I'll also talk about risk and protective factors for IPV by those typologies while highlighting the role of economic factors within that discussion. I will also talk about the evidence base for IPV prevention programs and policies, and I will also talk about the role of economic support in IPV prevention, and I'll spend a little bit of time talking about CDC's Economic Development Initiative that is partially designed to address IPV, and then I'll wrap up with some lingering questions. So to talk about IPV typologies, in order to adequately describe them, I need to take you back to the Duluth model, which I'm sure many of you are familiar with, the Duluth model. But it provides one of the most well-known frameworks for understanding IPV. And the Duluth model was devised in the early 80s in Duluth, Minnesota. And it was devised in the context where victims of IPV were attending educational groups, and they were interviewed about the behaviors of their abusers and factors that influenced why they stayed in violent relationships or returned to their abusers. And based on input from over 200 women, they developed a framework for understanding IPV, and that's what is depicted on the slide here. And their key finding is based on the power and control wheel, and that is what is actually in the figure here. And what is in that figure is that what they found is that abusers use an array of tactics to gain and maintain control over their victims. And some of these examples up there are using emotional abuse, using intimidation, coercion, and threats. The Duluth model describes some of the tactics typically used when we think of the stereotypical male batterer. Now, the power and control distinguish between different types of IPV, and the Duluth model formed the backdrop for Michael Johnson's work a decade or so later, and I'm sure many of you are familiar with Michael Johnson and his IPV typologies. But just as a little bit of a background, Johnson was one of the first to advance the notion that not all IPV is driven by the same factors. In fact, he hypothesized that the extent to which IPV is characterized by power and control, or some of the tactics described in the Duluth model, those are the things that differentiates between different types of IPV. And I have two different types listed up here that are the primary typologies that I will focus on in this presentation. The first is intimate terrorism. And this IPV typology is characterized by high levels of relationship violence. It is characterized by patterns of power and control by one partner. So the tactics described in the Duluth model are often the tactics used by intimate terrorists, and it's mostly perpetrated by men. And then a second type that Johnson identified is what is called situational couple violence. And in this case of IPV, violence typically does not characterize a particular relationship context. Usually neither partner is using coercive or controlling relationship tactics, so there's not a pattern of emotional abuse or physical abuse, for example. And it usually stems from an escalation in a specific conflict. So violence in this case doesn't characterize the relationship. So what about the role of economic factors related to these two IPV typologies? First, as Matt pointed out, all low-income individuals report disproportionately more IPV than those from other income groups. Hence, we know that there is great income inequality in experiences with IPV. Apart from that, though, economics play into some of the distinct coercive and controlling tactics employed by the intimate terrorist. And I have that part of the wheel circled on the slide here. For example, specifically, some of the tactics that intimate terrorists can use in terms of economic abuse is they can keep their partner from getting or keeping a job, for example, so they can maintain control over their partner by limiting their economic opportunities. They can also limit access to money by giving allowances, or they can keep their partners in the dark about family income. So those were some of the tactics identified within the Duluth model that relate to economic factors. Now, in the case of situational couple violence, I think that Conger's family stress model describes the role that financial stress can play in conflict escalation. And this model was initially posited to explain the relationship between family economic hardship and adolescent adjustment, which is in the bottom of the model or the figure there. And what I think makes this model relevant and related to situational couple violence is that it shows how economic factors like economic hardship leads to feelings of economic pressure within an individual, and that in turn can lead to feelings of distress. And then that, in turn, can potentially lead to couple conflict and violence. I think what this model shows is that distress is situational and not driven by one's controlling behavior. As far as other risk factors for each type, as far as intimate terrorists, they are more likely to have a history of violence within their families of origin. They're likely to have low education levels, and intimate terrorists do display more mental health problems compared to nonviolent men. On the other hand, the risk factors for situational couple violence are a bit different, and they include poor problem-solving skills, so you can see how that might lead to perhaps conflicts getting out of control. And those individuals also report difficulty in managing anger. Furthermore, as the family stress model would predict, low-income couples and relationships in which one or both partners are unemployed are more likely to report situational couple violence. So while the violence reported in situational couple violence tends to be less severe than that reported within intimate terrorist kind of relationships, both can carry serious risk for injury and harm, and thus both types require a public health approach to address all forms of IPV. But as you might guess, the appropriate response depends on the type of IPV that we are trying to address. So what does it mean to take a public health approach to IPV? Well, here at the CDC, it means something very specific. The focus is on prevention, so stopping violence before it starts. Second, it means taking a comprehensive approach or focusing on reducing risk and strengthening protective factors at multiple levels of the social ecology, so maybe having a program targeted at an individual as well as perhaps a relationship program, for example. It also means taking a multi-sector approach, engaging sectors ranging from employers to the justice system as well as our health systems. Fourth, it means that we implement prevention strategies to address risk and protective factors that is based on strong evidence, and I'm going to talk more about that evidence base in a second. And the sum of all these parts is that what it means to take a public health approach to IPV, it means that we apply our best science to reduce IPV-related injury and mortality. And just to remind you what the public health approach looks like, this is the slide that Matt presented earlier. And he did tell you about the NISVS and the surveillance efforts around IPV. I just told you a little bit about the risk and protective factors tied to IPV typologies. And I'm about to tell you about some of the prevention strategies or the evidence base around IPV prevention with an eye towards economic factors. So what is the state of the evidence for IPV prevention? As many of you know, it's not fantastic. In terms of where the evidence is, it's focused around four main areas. The first includes dyadic interventions. So these dyadic interventions essentially teach couples better communication and conflict management skills. And they have been developed with the goal of reducing couple conflict, reducing IPV, and enhancing relationship quality. And the Prevention Relationship and Enhancement Program, or PREP, is one example of these dyadic interventions. And they have demonstrated some effects on the primary prevention of IPV among adults. So there is some strong evidence for the preventive impact of dyadic interventions. The second class of programs involves interventions for female victims, primarily composed of screening for IPV in primary health settings that attempt to link women with services, to link women who screen positive for IPV with services. Now, the evidence on the effectiveness of these interventions is that referrals alone, so if you just screen and then give them a list of resources to reach out to, just doing that is not sufficient to prevent and control IPV. However, those programs that link screening and provide more intensive interventions have shown some promising evidence of effectiveness. Now, the third type includes what we call coordinated community response, which is a systems approach to address IPV. And what it's aimed to do is address the fragmentation and lack of coordinated services for IPV victims. An example is a host of family justice centers have been established across the country to coordinate services and resources for victims of IPV. Unfortunately, the CDC evaluations of coordinated community response have found no overall impact on these programs on IPV. Obviously, more follow-up studies need to be done. And finally, mandated interventions for male perpetrators convicted of IPV have focused on mainly confronting patriarchal gender norms, and it sometimes includes skill building. And evaluations of these mandated programs have shown modest to no effects on IPV recidivism. Now, what about the role of economic support in IPV prevention? This is a CDC-wide health impact pyramid, and what it basically is showing is that the CDC widely recognizes that socioeconomic factors play a large role in determining health, and how the health impact pyramid is organized is that addressing factors at the bottom of the pyramid is postulated to have a larger potential impact on health. So for example, any intervention that would address socioeconomic factors would have a greater impact on health in theory compared to perhaps clinical interventions that might address only a smaller population. So that's sort of the idea behind it. And in terms of the state of the evidence around economic support and IPV prevention, what we can look to are some policies that are already in place that address the intersection between IPV and socioeconomic factors. And they come in the form of multiple economic supports generally provided through various governmental programs. And I have a couple of examples listed here. They include temporary assistance to needy families, or TANF, as well as unemployment benefits. And what I want to note here is that there are special state provisions around each of these laws that take into account the difficult circumstances that surround IPV. For example, under TANF, many states have implemented a family violence option that requires IPV screening. referrals to community services, and waivers for those that could be harmed by time limit enforcement, for example. Unfortunately, none of these programs and policies have been rigorously evaluated for their impacts on IPV, and I think this is in part due to some of the data constraints around IPV measurement that CDC's NISVS is now trying to address, so that we can better understand the role of economic support in preventing IPV. But one program that addresses economic factors that has been rigorously evaluated for IPV impacts are microfinance programs. An example of a microfinance program is one created in Bangladesh by Nobel Peace Prize winner Muhammad Yunus, where he formed small lending communities that encouraged entrepreneurship among women. And, you know, in I have the definition of microfinance in that second bullet there. Let me see if I can point to it right here. It's the practice, but it describes a broader range of activities, and it centers around providing financial resources to individuals in order to build capital, whether it be small loans for entrepreneurship activities, whether it be establishing individual development accounts or savings accounts, or providing microcredit. So it's really represents a range of approaches aimed at improving one's financial status. So there's been some research that has explored the link between microfinance and health, primarily in international contexts, and I have here a map of some of the primary studies in this area that really look at the relationship between providing economic support to individuals and whether that has an impact on health. And I'm not going to go into each of these studies, but the one that is of particular interest around IPV is this chronic study that was conducted in 2008. And within that study, researchers combined a microfinance intervention with a gender as well as an HIV prevention curriculum. And using a cluster randomized design, they found that the microfinance intervention was associated with a 55% reduction in intimate partner violence among women in South Africa. Now, in terms of these other studies, the rest of the findings are generally favorable, but many are not randomized trials, and results seem very population-specific and context-specific. Thus, we at the CDC, when we saw this evidence, we had many questions about, you know, if we were to think about designing a microfinance intervention to address health, to implement with low-income populations within the U.S., there were big questions about the best ways to do that. So what we did is we brought together collaborators from across the agency, from 4 divisions specifically that are listed here, and we termed our efforts the Economic Development Initiative in order to try to think through how to best perhaps address some socioeconomic factors and then to see if they would have some impacts on health. Because we had questions about how to best adapt a microfinance intervention for use in the U.S., the CDC conducted a number of key intervention development activities. And the activities were varied, but they were all designed with one goal in mind. It was designed to provide multi-stakeholder input into the process. And the stakeholders are listed on your slide, and there are 4 of them. They include a core study group which were core experts in microfinance, as well as intervention development, intimate partner violence research, as well as HIV research. Second, we had a national consultation meeting, which gave us the opportunity to engage with a broader range of national experts in all of those areas. In addition, we formed 3 geographically diverse local advisory groups from cities with relatively high HIV STD rates to provide input on the intervention and implementation factors around it. Finally, as part of the project, we commissioned extensive reviews of the literature that informed the 2 products that are listed at the bottom of the slide. The key products was a theory of change or logic model development for the intervention, as well as an intervention manual. In terms of the key themes that emerged from experts and community stakeholders throughout that process that occurred 2 years ago now, these are the strong themes that emerged. First, the experts agreed that coupling an economic intervention with our more traditional health interventions, they felt that it was necessary and critical in order to address health inequities in the U.S. Second, experts acknowledged the needed collaboration between the health and financial sectors. In particular, with our local advisory group meetings, our community partners stated that it was rare to sit in a meeting where there were individuals from each of those sectors in the room organizing around one common goal. Furthermore, what I want to note is that there was a great openness and enthusiasm for addressing economic factors within the health system in 3 cities. I have the 3 cities listed on the slides, but just to mention them, they were Oakland, California, New Orleans, as well as Washington, D.C. Third, all the stakeholders agreed that there's a need to address racism within the microfinance intervention, but they had limited recommendations around promising ways to do that. Fourth, there was an urgency around the need to build safety planning and resources for those who may be experiencing intimate terrorism or situational couple violence. In fact, we have Michael Johnson as a member of our core study group who informed the intervention from the lens of those typologies that I discussed earlier. Finally, the stakeholders, the experts emphasized that it's important to foster community trust when implementing and developing the intervention. That means having the right implementation partners at the table from the outset who are established in the community. It also involves maintaining transparency and communication with community members around the intervention. So those are the big themes. Briefly, here's the theory of change, and I'm not going to go through it in great detail. I just wanted to show you that that's one of the products that came out of it. What I want to focus on very briefly is our intervention itself, the components of our intervention, which is on the left-hand side here. And just to drill down even more, in terms of what our CDC microfinance intervention, what came out of those efforts, is that it includes a combination of education and training as well as tools and resources to put the education into action. So that's what I have circled within this slide. And the educational and training components include financial education, business development training, and personal effectiveness and skill building, so things like time management and networking. The tools and resources, they include access to capital and case management, and support to address any issues like if there's IPV within, someone is experiencing IPV within the program. And then you'll see that I have beta version listed in the title, and this means that we're not finished yet with the intervention development efforts. There is a need to do some more refinement and component testing, particularly since the content that's focused on addressing racism is very much needs to be tested and refined. In terms of future directions, I already talked about the second point about refining the curriculum and component testing. Of course, additional partnerships, this is bridging sectors, so partnerships is a very key step in the process. In terms of building the evidence base, the last two are really important. Once this is developed, one of the next steps we see when it's ready, once it's been components tested and revised, is to do a trial to test its effectiveness to see if we implement a microfinance interventions with our more traditional health interventions to see if there's an added benefit to potentially addressing one of the socioeconomic factors or predictors of health to see if you get added benefits by addressing that within a health program. So lingering questions for the field, I'm just going to list these. I'm happy to talk about them more during question and answer, but in the interest of time, some of the lingering questions for the field include replicating and confirming IPV typologies. Second, the evidence for economic support and IPV prevention is promising, but it needs to be tested further. And third, there's a need to build and understand the evidence base for IPV prevention accounting for these typologies once they have been replicated and confirmed. So with that, I thank you, and I welcome any questions.
Hey, Jen, this is Ann Menard again. We did have one question come in, if you could answer while they're bringing up my slides, and that is one of the participants asked you to give an example of intimate terrorism violence. She feels like she understands high levels of violence, but wants to make sure she understands this term that's new to her.
The intimate terrorism. So it's so the contribution of the typologies is that it really pays attention to relationship dynamics and puts IPV in the context of relationship dynamics. So the idea behind intimate terrorism and what characterizes relationships that can be characterized as intimate terrorism relationships is that there is repeated, sometimes severe acts of violence that are occurring in the relationship, that the basis for some of the violence or what is motivating some of the violence is this power and control. So it's really, it's really building from that Duluth model. So, it's usually one partner trying to control the other through a variety of tactics that are abusive and violent. So that's sort of what characterizes a relationship that has intimate terrorism as an aspect of that relationship. It's controlling. It's, when we think about the stereotypical how IPV is characterized in movies, for example, what they're usually characterizing is a relationship in which there is an intimate terrorist doing repeated acts of violence on another partner. So it's really what comes to mind when we think about IPV typically, and it's not the situational couple violence where it might happen if you're tired or stressed or whatever, and a conflict just escalates out of control. And what really distinguishes between the two is the use of the tactics to control the other partner.
Thanks so much. So we're going to move into my presentation, and it really builds on both Matt's and Jen's the information that they shared. So I'm going to talk a little bit about what else we know about intimate partner violence and financial instability, and what are the implications for practice on the ground and state and federal policy. I thought it was important to start with the voice of a survivor, and one that speaks to the importance of addressing economic impacts of violence in our work with survivors. So this survivor who received services from the Washington State Domestic Violence Program. This program saved my life. I had no place to go, no money. I now have a job, an apartment, and I'm learning how to get over my fears. I don't have nightmares anymore thanks to counseling. So this combination of support that this survivor identified as critically important for her. What else do we know about intimate partner violence and financial instability? We have, there are a number of studies related to housing. A 2005 Florida study examining the experiences of violence among 800 homeless women found a significant number of women were victimized in their lifetime, and almost 1/4 of the women indicated that violence was one, if not the main reason they were homeless. Another 2003 study that I think Shondell mentioned in her introduction found that survivors are more likely to experience housing problems if they experience more severe violence, contact fewer formal systems, so in other words are more isolated, have less informational support, and receive a negative response from welfare. So these are all things that research has told us increases financial or housing instability. A 2008 study showed that housing is one of the main needs identified by survivors at the time of entry into a domestic violence shelter. 84% of participants in this study of 3,400 shelter residents, domestic violence programs across 8 states, reported that they needed help with finding affordable housing. Almost 60% of participants in a study of 1,500 survivors seeking non-residential services, so non-shelter services from domestic violence programs, indicated needing support around economic issues such as housing, employment, and public benefits. Over half, or 51% of the study participants, reported themselves to be in financial trouble, including many not being able to pay their bills. Domestic violence survivors who participated in the 2008 shelter study ranked housing and economic assistance among their primary needs. 93% were looking for help with finding affordable housing, job training, transportation, education, and support around managing money. Another 2008 study found that financial abuse was present in almost all abusive relationships, meaning the abuser is purposefully making the victim financially dependent on him or her. What about intimate partner violence and employment? Studies examining women's employment in relationship to domestic violence victimization show that women experiencing domestic violence do not differ in their current employment status or in their desire to work from women without a history of domestic violence victimization. Nevertheless, domestic violence appears to substantially affect women's employment in that compared with women who have not experienced domestic violence. Women who report domestic violence victimization report more days arriving late to work, more absenteeism, more psychological and physical health problems that may reduce their productivity, and greater difficulty maintaining employment over time. Other research underscores that these problems are exacerbated among women with disabilities who have experienced domestic violence. Still, unemployment can also have protective effects for domestic violence victims. Employment provides not only important financial resources, but also may raise a woman's or a survivor's self-esteem, thereby strengthening her ability to cope with or end an abusive relationship if that's her pathway to safety. While these studies focused on female victims of domestic violence, these protective factors may also work similarly for male victims of domestic violence. This second bullet, research also shows that abused employed women who receive social and tangible support from coworkers and supervisors experience less social isolation, improved health, and fewer negative employment outcomes. Domestic violence, as I'm sure many of you know, often spills over into the workplace, with batterers sometimes stalking, assaulting, or murdering their intimate partners at work. You see two bullet points here that talk about what we know about the domestic violence-related injuries to women and their costs. $5 billion a year in medical expenses and lost productivity. About 50% of this cost is borne by the private sector in the form of payments for health insurance and sick leave. Employed women who experience domestic violence, especially if it involves stalking at work, may consequently lose their jobs or give them up in the hope of increasing their safety, resulting in another pathway to financial instability or poverty for domestic violence victims. This has already been mentioned, but I also want to underscore in the 2011 non-residential services study that I mentioned earlier, among the survivors seeking services for children, over 41% were looking to the domestic violence program for help with obtaining child support. We know from other research that over 90% of women with current or former abusive partners want to pursue child support. They feel it's an important part of their economic security if they can do so safely. So that's the rub, and we're going to come back to that point. We know from research and experience that some victims of domestic violence may not want to pursue child support because of the dangers to themselves or to their children, including violent retaliation or an abuser gaining information about where they are through the child support process. TANF has already been mentioned, the Temporary Assistance to Needy Families program. We know that from research and experience that women with abusive partners often use welfare, or now called the TANF program, as a bridge out of these dangerous relationships. We know that between 40 and 60% of current welfare recipients have experienced domestic violence at some point in their lives, and up to 25% report that the abuse is a current problem. The adoption of the family violence option that Jen mentioned was optional for states, although most have adopted it, but only a minority, from 0.5 to 3% of TANF clients disclose domestic violence to their caseworkers, request a family violence option waiver or exemption, or utilize domestic violence services. In 2009, the National Resource Center on Domestic Violence, with our partner Legal Momentum, conducted a survey which received over 600 responses from across the country, and there was a report issued which we called Not Enough, What TANF Offers Victims, and there were three basic findings: that TANF is important to domestic violence victims. It can be a very important resource for them. That TANF can make a significant difference when it works well. And the third finding, that TANF can make a significant difference when it does not work well in terms of complicating and making survivors even more vulnerable. Here is one of the quotes from the respondents at the Not Enough, What TANF Offers Family Violence report. This describes what happens when TANF works well. I had a case where a client showed up for an interview, was referred to me, picked up her children, was helped to flee all in 6 hours. She literally did not have diapers or a bottle even. She was given transportation vouchers, clothing vouchers, diaper vouchers. Then TANF put her up in a hotel in a new community and helped her get into shelter there. It was incredible to see them all coming together and taking action. Overall, she left knowing that there were people who care and will pull out all the stops to keep her and her children safe. So we heard about what happens when TANF works well. And here's a reflection of from one respondent about what her clients say about TANF. I don't want to tell my worker about the violence. She'll just come and take the kids. A welfare check won't even pay my rent if I move out. I'll also need HUD assistance, and there's a huge wait list. I can't pay utilities or buy my medicine. My friend got TANF and got a part-time job through it, but the job made her child support go down. What's the point of trying? So there's obviously a lot of work to do in this area. I want to end this part on a positive note. We also have some emerging evidence that asset building can have providing support to domestic violence survivors to increase the assets they have, the financial assets they have, can make a difference. A study of the savings outcomes of 125 survivors participating in the Federal Individual Development Account, or IDA program, found that 2/3 of women reached their savings goals, and 76% made at least one matched withdrawal purchase. So that under the federal program can be a house. They can use the funds saved to purchase a house, to start a small business, or to support employment. So these are very important outcomes. Also interesting is early unmatched withdrawals. In other words, withdrawals that were not planned were often used to preserve housing, which may also have maintained safety. So savings and asset accumulation strategies have the potential implications for survivors' long-term economic stability and their safety. And I think you saw some promise of that in the work that Jen was describing. So what are the implications of this research and experience-based evidence for practice on the ground on state and federal policy? So what we know is this, as our other presenters have already reinforced in their presentations. There is a complex interplay of intimate partner violence and economic factors in victims' lives. This can involve dependency on an abusive partner to provide financial support for the family. It can involve job loss or lost wages from workplace interference or sabotage by an abuser, or time off needed to recover from an assault or an attack. Unfinished education or training due to lost class time or relocation as a result of domestic violence. barriers accessing public benefits due to the abusive partner's sabotage of job or education, or trauma impacts of domestic violence for the survivor or their children that have to be tended to, or other factors. The financial abuse can result in debt from health care, costs associated with domestic violence, relocation costs that are necessary, or replacing damaged property. It can also involve damaged credit from abusers financially crippling the survivor through joint debt or other tactics. It can result in survivors being rejected from rental or loan applications due to bad credit or debt. It could involve eviction or damaged tenant history from law enforcement involvement as part of the response to domestic violence. It can result in a survivor's inability to find a job with unfinished school employment gaps due to violence, or a criminal record due to being coerced into crime. And it can also involve a loss of assets with long-term implications if an abuser continues to control income. So these are complicated, and I think that's been it. I think all of the presenters have used the word complex or complicated. So when we think about policies and practices or implications, there are policies and practices that we can implement, but first I want to just raise up some of the things that we would love to see not happening anymore, because they make it difficult for us as advocates, and certainly make it difficult for survivors who are trying to deal with both intimate partner violence and economic abuse. The first is we'd like to stop hearing from workers in various systems that safety is not my job, treating domestic violence as a parenthetical issue rather than one that's central for anyone who is in systems that works with families, is just irresponsible. So that's something that we would like to hear less of. We'd also like to, well, we know that information and confidentiality are central to survivor safety planning. So we'd also like to see us stop to strategies or approaches that undermine victim safety planning. How does this happen? This happens when disclosures of domestic violence, which are very difficult for survivors. It's very difficult for survivors to disclose something as challenging as domestic violence. But when there are disclosures, when those disclosures do not lead to needed services or support. Also, when we fail to provide accurate information about programs or services and requirements, how personal information will be used, assurances of confidentiality, and the safety accommodations or services that are available. This undermines a survivor's ability to engage in safety planning when they're not provided with this kind of information when they're seeking services. We also need to stop underfunding domestic violence programs and continuing to ignore the unmet need. We know from a one-day annual census conducted by the National Network to End Domestic Violence, one day in September 2013, which is I think the third year that the census was done, victims made over 9,000 requests for emergency shelter, transitional housing, and other services that could not be met because domestic violence programs did not have the necessary resources. This was on one day in September of 2013. So that's something we need to be addressing. It's also been established that many advocates are paid wages that make them income eligible for food stamps. That is not a responsible way to structure our response to a problem as complex and important as intimate partner violence. There are also things that we can do better. And I've tried to organize them here in a way. On a practice level, when domestic violence is disclosed, something helpful should happen. There should be a warm referral to services. In other words, that there should be connections on a community level across programs that domestic violence victims are likely to be looking to for assistance. There should be accurate information provided about safety planning. There should be tangible assistance provided. We should be ensuring that there's well-trained staff with meaningful relationships with the domestic violence community. This is basic. There should be more yellow light responses, and by that we mean responses that proceed with caution, that understand what safety risks exist for an individual seeking services, and a commitment to address them as a help or to help a survivor safely exit the system. There should be more robust collaborative partnerships between domestic violence programs, responsible fatherhood programs, and other community groups working with economically vulnerable families. And we're seeing a lot of those develop. So there's some great models being designed. We can also do better. Here are some very specific policies and practices that respond to the economic impacts of intimate partner violence. Criminal or civil protective orders that include economic relief provisions. Access to unemployment benefits for victims who lose jobs due to domestic violence, sexual assault, or stalking that an increasing number of states are implementing. Housing policies that allow victims to break leases or modify security without fear of eviction or excessive costs. Restitution to cover abuse-related legal fees, mental health care, or property damage. Paid sick and safeties that victims can use to address the health consequences of violence, filing for restraining orders, or cooperating with police investigation without compromising their jobs or economic stability. We can also make TANF a more effective safety net for survivors, requiring rather than leaving it optional as state option, and for TANF and child support agencies to have robust, comprehensive, integrated responses to domestic and sexual violence issues, including training and flexible family violence exemption and work requirements. We can do a lot more to ensure HUD's policies, the housing and urban development policies, and funding provide support for a full range of housing options that survivors need. And we know that this continuum of housing needs includes emergency shelter, transitional housing, supported housing, and other permanent housing options that account for safety concerns. We can create greater access to emergency relocation and assistance funds for survivors who need short-term help, such as to repair a car, to pay a security deposit that can mean the difference for themselves and their family. Increased emphasis on asset-building strategies and programs designed for survivors, and targeted employment services for domestic violence survivors. And last, we can review and update and reissue directives and fact sheets regarding access to federally funded services for immigrant survivors of domestic violence, as well as language access requirements, which are important to ensure that there are not barriers, that immigrant survivors and those who have English as are not able to communicate in English are able to access these critical safety net services. There are a number of other public policy and approaches that will increase economic stability for all folks living in poverty or at the edge, and these include workplace violence policies and procedures, an increase in federal and state minimum wage, including living wage policies, pay equity policies, and workplace flexibility policies. And I want to end on a policy note. This is also from our Not Enough, What TANF Offers. When a victim gets a case manager who knows the system and family violence, it works well. They advocate for her. They help her through the system instead of creating barriers. We recently had a victim facing lethal danger who needed to get safely to another state. The victim got her grant quickly, and this is her TANF grant, and was able to get safely out. When our agencies work well together, we were able to save lives. So with that, I'm going to turn it over to Seth, and I know we're running a little behind time, but Seth has some important information about some of the research projects that Office of Policy and Research and Management is funding.
Great. Thank you so much, Ann. I'm just going to speak very briefly about some new exciting research that my office is taking on in collaboration with FIPSA, the National Domestic Violence Hotline, and another office within the Administration for Children and Families, which is called the Office of Family Assistance. On the slide you see in front of you, you see FIPSA there, the National Domestic Violence Hotline. My office is the OPRE that's there, the Office of Planning, Research, and Evaluation within the Department of Health and Human Services Administration for Children and Families. The Office of Family Assistance, which is the one noted at the bottom, is the office responsible for such programs as TANF, programs for health profession grants, as well as programs for healthy relationships and responsible fatherhood. We have recently initiated 2 new research projects. The first one we're calling RIVER. I like acronyms. This stands for Responding to Intimate Violence in Relationship Programs. We have collaborated with FIPSA and the Office of Family Assistance to initiate a project to build a framework for addressing intimate partner violence and healthy relationship programming. ACF oversees the grant program on healthy relationships, which funds organizations to provide healthy relationship classes to low-income couples, among other services. Despite the prevalence of intimate partner violence among populations served by these programs, there's little consensus on how programs should best serve couples experiencing violence in order to maximize their safety and well-being. Further, there's an open question regarding whether program responses to intimate partner violence are effective. This project will document the intimate partner violence experiences of populations that participate in our healthy relationship programming. It will document current program approaches to intimate partner violence, and it will build a framework for understanding how we can address intimate partner violence in the program context. And lastly, it will propose parameters for intimate partner violence protocols in this important human service. The second research project that we have recently initiated, we're calling Advocate, which stands for the Accomplishments of the Domestic Violence Hotline, Online Connections, and Chat. This is a descriptive study which will document the activities and achievements of the National Domestic Violence Hotline and the National Dating Abuse Helpline. I should mention that we are working on this project in collaboration with FIPSA, as well as the National Domestic Violence Hotline and the National Dating Abuse Helpline. We will be, as many of you may be aware, the hotlines are not simply telephonic assistance. There are also there's also an online chat feature that's available. Texting is available on the Dating Abuse Helpline, and of course they both have websites. This project will be documenting the processes and outcomes of the multiple modes of assistance. And it will also propose new ways to continuously document the successes of these services. If you have any questions about these projects, please don't hesitate to contact me. My contact information is here on the last slide, and I believe the slides are also available for download, and you can feel free to contact me at any time. I'll turn it back to Ann.
Beth, thank you. So I think that we have answered all the questions that were posed during the presentation, which is great, and you have all of our contact information. So what I'm going to do is turn it back to Shondell, who will close us out.
Thank you all very much for your amazing presentations. We really appreciate having the opportunity to partner with you all to discuss not only the prevalence of intimate partner violence, but provide intense descriptions on how this weighs out for domestic violence survivors and acknowledging the impact across various systems. The FIPSA program will be continuing to work with our partners throughout the year, and we will keep you all updated on opportunities to raise awareness about tools and resources that are developed, and also have opportunities to join us for future webinars to discuss these topics more in-depthly. In terms of follow-up, we will be sending you all out a recording of this webinar, as well as a link to the studies and reports that were referenced today. I want to thank you all very much for joining us. I want to thank our colleagues from the CDC. I want to thank our partner, Seth Chamberlain from OPRE, as well as Ann Menard and her team at the NRCDV for facilitating this webinar today. This concludes our webinar, and we will be following up with the link in about a week or so to the recording. Thank you all again for your time and for joining us.
That concludes today's conference. Thank you for participating. You may disconnect at this time. Speakers, please hold for the post-conference